Good afternoon, everyone, and welcome to the 5th annual Margo Simon Golden Memorial Webinar. Before we begin, I would like to read the Massachusetts Breast Cancer Coalition's mission statement. Massachusetts Breast Cancer Coalition is dedicated to preventing environmental causes of breast cancer through community education, research advocacy, and changes to public policy. It is my privilege to open this important event, which holds a special place in my heart, as well as the heart of the MBCC community. Today, we honor the remarkable legacy of Margo Simon Golden, whose leadership and dedication as MBCC's board president helped shape the foundation of our mission. Margo's unwavering commitment to breast cancer prevention and her vision for a better future continue to inspire us all. Her work reminds us that every effort we make together has the potential to create lasting change. Now, please join me in a brief moment of silence to honor Margo and pay respect to her loving family. Thank you. This webinar is not only a tribute to Margo's life, but also an opportunity to celebrate Dr. Tamara James-Todd, this year's recipient of the Margo Simon Golden Distinguished Service Award. Dr. James-Todd is an epidemiologist whose work is transforming our understanding of women's health. She serves as a professor of environmental reproductive epidemiology in the departments of environmental health and epidemiology at the Harvard T.H. Chan School of Public Health. Dr. James-Todd's research examines the powerful role chemicals play in pregnancy, chronic disease development, and health disparities. By uncovering racial, ethnic differences in exposure and bringing attention to the impact of everyday personal care products. Dr. James-Todd has advanced both science and justice, developing strategies that improve health outcomes for women today and future generations. We are fortunate to have Dr. James-Todd leading today's webinar, Environmental Justice and Women's Health. I'd like to acknowledge Dr. Barbara Malkus, MBCC Board President, who will be moderating the discussion and Q&A following Dr. James-Todd's presentation. I would like to extend my heartfelt gratitude to Margo's beautiful family for their thoughtful contributions in planning and organizing today's event. Margo's husband, Neil, her children, their children, Andrew, Craig, Andrew's wife, Kate, their grandchildren, and the entire family have played an invaluable role in supporting MBCC and advancing our mission throughout the past many, many years. We are also privileged to have attorney and MBCC board member, Andrew Golden, presenting the Distinguished Service Award later in the program. Thank you, everyone, for joining us today to celebrate Margo's enduring legacy, honor Dr. James-Todd, remarkable contributions, and engage in this important conversation about environmental justice, women's health, and prevention. This would mean so much to Margo. Your presence and remind us that we are strongest when we work together. As Margo would always say, and the family knows this is true, and anyone who knew her, Rachel Carson was right. And now it is my honor and privilege to introduce Dr. James-Todd. Dr. James-Todd, thank you for your leadership and for sharing your insights with us today. Thank you.
Just want to also echo what Cheryl said, in that I'm incredibly grateful and honored to be here with you all today, and to be presenting in honor of Margo Simon Golden as a part of this webinar. I'm going to go ahead and get started, and it should be no surprise that my first slide really speaks to the person that I have learned Margo was. I did not have the privilege or honor of meeting her. But what I have learned through conversations with her family and through conversations with her colleagues, and also the opportunity to learn about her via the amazing work that she has done, is that she was indeed a committed leader, a passionate advocate, and a change maker. And she really dedicated her work in service to preventing breast cancer. And I put this quote here, that her goodness and hard work has made the world a better place for all of us. And I want to highlight that all of us, because that is really seated in the crux of the presentation today. And I'll also just note that when I mentioned to my family that I was receiving the opportunity to give this lecture, and I mentioned that Margo's family shared that she really asked the question why, and that led her service. My family smiled and said, "Oh wow, that's powerful, because that's really your underlying question as well. You really see the power of asking why," and you'll see throughout this slide or this presentation that that is also an anchor of this. So I'm honored to be here with you all today and to have this opportunity to really dedicate this presentation to Margo. And to that end, I really want to start with the question of how do we make the world a better place for all? And there's ongoing discussions about how we might go about doing that. And I would say in the context of health and thinking about breast cancer in particular, it's really in being able to see and understand what is happening, what's going on in the world around us, and why might there be this issue still going on despite all of our research, and why are some groups more vulnerable, more at risk than others, and what can we do to eliminate this? And I would just say that there's the goal, as Margo really put it, and as Cheryl reiterated, is we want to improve health for all to ensure that everyone has the ability to achieve their best health, which is really at the crux and core of this concept of health equity, and recognizing that there's a variety of inputs into being able to achieve better health for all that include improving economic, social barriers, access to health care, and reducing disparities. And to that end, I want to note that in the concept of all, we have to recognize that not everyone has the ability to achieve their best health, and that there are a variety of different drivers that can impact someone's risk of disease that can also impact their ability to remain healthy and to to navigate a disease process. And that can range from differences in the identities that we all carry. There's differences in individuals' social and economic status, their age, their language, ability differences. I'm going to talk a bit today about race and ethnicity as it relates to breast cancer, but body size, place, so where you live, your sex, and your religion. And these things all intersect with one another and can really influence our ability to, what diseases we might be more susceptible to. And they also impact our ability to achieve our best health when managing those diseases. And breast cancer, I started off now 20 years ago as a student at Columbia, really interested in understanding this issue that doesn't necessarily seem to, it's not gone away. Well, we see that breast cancer incidence does vary by one of the social factors that I mentioned in the previous slide, race and ethnicity. And mortality from breast cancer also it differs by one of these social factors. And I could have mentioned and highlighted other social factors as it relates to health disparities. But what I really want to get at is going back to the power of Margo's question. Why? Why do we see a much higher incidence of breast cancer in white individuals, and particular white women here, but a much higher mortality rate among Black women? And as a student 20 years ago at Columbia University, I was really struck by this and wanted to ask the why. And in starting to ask that question, I became really interested in better understanding what was happening as we looked at breast cancer, right? So these data come from a study that looked at triple negative breast cancers and different types of breast cancers. So the kind of really difficult to treat breast cancers. And this is looking at different age groups by race and ethnicity. And so again, difficult, the kind of most difficult breast cancers to treat to some extent. And what you're seeing here with these different bars representing the rate of these breast cancers per 100,000 individuals. And you see that the highest rates kind of across each of the age groups is for these difficult to treat breast cancers are in Black individuals. And I kind of first learned of this even as a master's student back at Boston University years ago, and was curious, like what's driving that? And one could say that you know, what might be driving these kind of more non-responsive breast cancers could be some differences in risk factors for breast cancer. For example, some of the kind of social and demographic risk factors include age, sex, family history, or lifestyle factors such as, you know, kind of obesity and body size, alcohol use, smoking, and physical activity, or some of these reproductive risk factors ranging from pregnancy complications like preterm birth to changes in menstrual cycling, mammographic density, and oral contraceptive use, for example. But one of the things that struck me as a young student, really thinking about this was, while there absolutely are differences in breast cancer risk factors by a variety of social factors, not just singling out race and ethnicity alone, was that there seemed to be somewhat forgotten risk factors in the study of this. And, you know, obviously there was, you know, work that had preceded my starting to study this 20 plus years ago, but the concept of environmental risk factors really didn't, you know, even when you go to your own doctor's office, it is rare that a doctor, a clinician will ask you about your environmental risk factors. And, you know, I was really struck by that, mainly because I was thinking about my own environment in which I grew up in, and what it could potentially have impact on for the health of myself and other folks within my community. So when I talk about environmental risk factors, I mean things like air pollution or toxic metals exposure, or climate factors like extreme heat exposure or experiencing a natural disaster. But perhaps one of the things that really kind of led to where I am here now in the studies that I do, is really thinking about these chemical exposures. And one might say, well, what do we know so far about these environmental risk factors as it relates to breast cancer? So I just want to give you a few examples of this. This comes from work from other scientists, but just to kind of highlight a few examples. We know that having higher exposure to air pollution is associated with a 3 to 5% increased risk of breast cancer for each, you know, increase, this 10-unit increase in air pollution. So while that may seem modest, when you get to heavily polluted areas, this can be quite problematic. We know that with respect to kind of toxic metals exposures, about a 30% increased risk of breast cancer from higher mercury exposure, particularly from the air pollutants. So I think we often think about air pollution, but we don't understand that in the actual air, there's these heavy metals like in toxic metals like mercury, for example. So there's some studies that have indicated this. There's studies looking at a variety of chemicals, and we'll spend more time on this today, but chemicals from hair dyes and hair straighteners with associations that are, from, range hovering around twofold increased odds of breast cancer, particularly among certain subsets of the population. And again, going back to that previous point that I raised about, why do we see more mortality in certain groups of individuals? These were individuals that identified as being Black and who are using these home kit for hair dyes. We also saw an 82% increased odds for having larger tumors among people who used hair relaxers or these hair straighteners. And then lastly, there's a lot of folks are becoming increasingly aware of what are called forever chemicals, also known as per and polyfluoroalkyl substances. And having higher concentrations of some of these, in particular PFNA, is associated with a twofold increased odds of these estrogen receptor negative or ER negative breast cancers that I had mentioned earlier. So when we're thinking about this, this is what we know overall. And what I want you to consider is what happens when someone lives in an environment or in a community that may have more air pollution, harmful metals exposures, due to a variety of factors, be more likely to use some of these chemicals in consumer products, both with kind of the use of hair relaxers or dyes or nonstick substances, or pollution from industry into their waterways with some of these forever chemicals. And so that kind of gets to the next section of this presentation that I want to give, which is, what do we know about these breast cancer risk factors that are environmental as they relate to disparities, and what might that tell us about breast cancer disparities? So if we focus on air pollution for a second, what we know from studies is that individuals living in certain communities, particularly lower income communities and communities of color, have much higher air pollution exposure. In a study that was done by Christopher Tessum and published in PNAS, there was a finding that non-Hispanic Black individuals are exposed to over 60% more air pollution than they produce in their communities. Very similar finding for Hispanic individuals, 56 more pollution compared to what they produce within their communities. And on the flip side of that coin, non-Hispanic white individuals are exposed to 17% less air pollution than they produce. And so this inequity is really concerning when we think about, breast cancer prevention, if we know that living in increasingly more air, polluted areas could have impact. And that being said, we know that overall air pollution has been declining with the Clean Air Act. But that decline, I'm just showing you here through 2015, is I think somewhat in question for two parts. One, we still see within certain communities and within certain populations, still, even with that decrease, they have higher concentrations of air pollution. And two, questions regarding what impacts today, whether or not we've kind of plateaued on reducing air pollution, or if we're in a setting where we might be seeing increases again. So, more to consider in the context of thinking about reducing harmful exposures as it relates to a variety of health outcomes related to air pollution. But let's also think about metals exposures. And here I'm showing you data that was published in the Morbidity and Mortality Weekly Report back in a few years ago. And this is just looking at the mean concentrations of blood lead levels for young children as an example of differences in toxic metals exposures. There's no acceptable level of lead that is safe. but we do have cutoffs. But here, while we've had significant decreases in lead poisoning here in the United States, it's worth noting that both Black and low-income families, so this is the federal poverty level, so individuals that are more than 130% below the federal poverty level, to have higher concentrations of lead and lead exposure. And when we're thinking about climate factors, I'll highlight two. Here I'm highlighting exposure to extreme heat due to urban heat island intensity. And I'm showing you the distribution of the mean surface urban heat island. So, you know, if you've ever been on a playground during the summer and there's no trees around, and it's the kind of the hot asphalt kind of generating heat up. That happens in many communities that do not have tree or green space coverage. And so in this distribution, you see that the mean of the temperature, so from left to right, the right-hand side of this graph means more heat exposure. So this distribution is showing that it is shifted to the right, meaning more extreme heat for people of color compared to the non-Hispanic white population, indicating that there's more extreme heat exposure in these populations. But it's, you know, when you're thinking about climate factors, it's not just extreme heat exposure, it's also other factors like flooding events. For example, in the summer, we saw a devastating event, but these events are happening all over the country with flooding. And what we also know is that there are social factors, what investments have been made in communities and what investments have not been made in communities and what's driving that. So even here in the city of Boston, those investments into a community historically were driven by a concept or a set of policies known as historic redlining. Populations or communities of color or immigrant communities were much more likely to live in communities that were less invested in, and mortgages were less likely to be given to those populations compared to communities that were predominantly white. And that has had real impact because it turns out that there is a greater chance of having and being at flood risk if you lived in a community that was historically redlined, meaning that it was less invested in. And many of those communities are still struggling today, even though those policies have ended more than 60 years ago. When we look at these chemical exposures, so moving to chemicals, I mentioned these per and polyfluoroalkyl substances, or PFAS chemicals, also known as forever chemicals. These are the most common place in which these chemicals are found, and sources of exposure really come from contaminated water due to kind of military, airport usage in firefighting foam, but also in other consumer products. And it used to be that folks didn't really note a disparity or they saw higher concentrations among higher socioeconomic status individuals or non-Hispanic white individuals, but it actually matters where you're looking. And so what I am showing you here are concentrations of two different types of forever chemicals. And the higher those bars, the higher the concentrations are. This is looking at different racial and ethnic groups and different cities. So here in the Boston area, Black individuals have significantly higher concentrations to these PFAS chemicals, particularly for PFOS, which is the panel on the right-hand side here. So it matters what you're asking about. And another class of chemicals that I'll just mention that I'll talk a bit more about today are these more non-persistent chemicals. So I mentioned those PFAS chemicals are called forever chemicals because they hang out in our environment and in our bodies for long periods of time, sometimes up to decades. This class of chemicals, phthalates, which are also known as plasticizers, our bodies metabolize these, they come out of our bodies pretty quickly. but they're used in personal care products, diet and food packaging, and medical tubing and medications. And I'll just note what you're seeing here is different types of phthalates. That's the kind of alphabet soup. The ones on the left-hand side of both panels represent those that are found more commonly in our fragranced products like perfumes and hand lotions and so on. And the ones that you're seeing more on the right-hand side represent those that are more commonly used in food packaging. And what I hope and note that you might be seeing is when you're looking at the panel on the left-hand side, the red bars represent the concentrations or levels in women, blue in men. And so women have much higher concentrations of these kind of personal care product associated phthalates and compared to men. And then if you look at the right-hand panel, non-Hispanic, Black, and Mexican Americans have much higher concentrations of those same personal care product driven chemicals. And I'll note that these chemicals are known to be reproductive toxicants and have other harmful effects. Another class of those chemicals are parabens, which are used for their antimicrobial properties. They're used in personal care products, but also in foods such as the processed muffins or tortillas, things that you can find in stores. They extend shelf life, but you see these striking differences when you look at these two different types of parabens. And we're looking at this by race and ethnicity, and even at ages 6 to 11 years old. So children have, non-Hispanic Black individuals have much higher concentrations of these chemicals. Again, there's been associations with a variety of reproductive outcomes, poor reproductive outcomes with higher exposures to these chemicals. And when you think about this across the board, there's really these differences in the cumulative environmental exposures, many of which are linked to breast cancer risk or breast cancer treatment and survival. And so in thinking about this, there are certain groups that may be more exposed. And going back to this point of how do we achieve the best health for all? It doesn't mean lowering or decreasing the health of, a group that is already, achieving better health. It just simply means how do we raise the health of everybody here? And a big part of that is making sure that we reduce harmful exposures across the board for things particularly that we know impact conditions such as breast cancer. So that brings me to the examples I'd like to share with you all from my own research. And I'm going to really focus in on that class of chemicals I mentioned to you that were known as plasticizers to give this example about beauty justice and how it really was leaning into the asking of why. Why do we see these differences in exposures? Why do we see the differences in breast cancer health outcomes? And more importantly, what can we do about it? And so I'm going to give two examples at two different time points in the reproductive life course, one at menarche and one in pregnancy, both of which are risk factors that I'll highlight related to breast cancer. But what exactly is beauty justice and why am I even talking about that? Perhaps people have not heard of that terminology. And I'll start with this concept of beauty standards, because oftentimes when I bring this up, people are like, why would you even talk about beauty at all? And when we're thinking about environmental risk factors, beauty's frivolous, to say something is beautiful, what does that even mean? And I'll say beauty has actually a lot of power. It has economic power in the workplace. People, even people who are taller, I recently heard a study where people who are taller are more likely to be in kind of leadership positions and earn more money. I mean, it's probably, I'm a very short person, but I think it is important to note that how you show up in the workplace matters. And so there's economic gain in adhering to the beauty standards of a particular society. There's also, to that end, social mobility that comes with this. And there's a variety of studies that really highlighted this. Social acceptance, I mean, not only within the kind of society at large, but even within our own families and communities, what we identify or deem acceptable. I mean, just think about, you know, what we as parents perhaps even say to our children about, like, don't leave the house, you know, looking a particular way if you're going to like a celebratory or some sort of special event. So thinking about these things. And then there are other forms of validation, again, from friends and family that kind of reinforce these points. So achieving beauty ideals really has impact. And the reality is, this is a multi-billion-dollar industry for a reason. But how does that have any impact on environmental health risk, particularly as it relates to breast cancer risk? And I want to highlight a few here. For example, skin lightening creams. So having fairer skin, particularly among communities of color, is often deemed more desirable. Except skin lightening creams more commonly contain harmful chemicals, including mercury. And I mentioned mercury earlier as a breast cancer risk factor, having higher exposure to that. Hair straightening, I mentioned earlier, contains chemicals that we know are carcinogens, such as formaldehyde, for example. I'll spend a little bit more time on these scented fragrances, but they contain these plasticizer chemicals. There's hair removal creams, other cosmetics that have contained lead, such as the bright red lipsticks, and nail polishes, which contain some of these plasticizer chemicals as well. And there are differences that are both gendered and are also based on different kind of cultural factors within our society. But the example that I'm going to give right now is transitioning to these environmental chemicals and looking at age at menarche, or when a girl starts her period. So for each year earlier in which a girl starts her period, there's a 20% increased risk of breast cancer. So really being able to identify and you know, what might be driving, you know, any linked with early puberty might be helpful in reducing breast cancer risk. And I mentioned that, you know, about 20 years ago, I became interested in this because when I was a master's student, this issue of Time magazine hit the bookshelves at our local supermarkets and so on. And at the time, I was working in a breast cancer lab of Dr. Tim Lash, who was doing a lot of molecular biology work, molecular epidemiology work, and trying to understand disparities. And I was struck by this because it was something that I had noticed in my own community, that there was much more development at much earlier ages within certain subgroups within my community compared to others. And at the same time, there was this issue, this publication that came out looking at a national network of pediatricians' offices that highlighted the differences that I had anecdotally seen. So here they have thousands of young girls, data on when they started their periods or reached age of menarche, and they just described that based on race ethnicity. So by age 12, 35% of white girls had reached menarche compared to 62% of Black girls. And being the master's and then finally eventually doctoral student that I was really curious about this. I started asking why. And as a part of the why, what I also learned was historically this was not the case. In fact, these data, which were published in the late 90s, were the complete counter of data that were published earlier on in the 1930s and 40s, where you saw the complete opposite of this. And at the time when the authors wrote this work up, they really focused on, you know, they weren't sure what the reason was, but one of the kind of rationales they provided was maybe there were biological differences. Maybe there was something about the genetics that was really driving this. And that didn't make sense to me as a student, really thinking about the historical piece, genes just don't change that fast. So what else might be going on? Fast forward a little bit, and I just want to note this, that the other thing, and the authors mentioned this back even in the 90s, but these data, which come from Dr. Shruti Mahalingaya's lab with Sifan Wang being lead author on it, note something that the authors in the 1990s had also noted, that there was this decline that was happening across the board for all groups of people with respect to age at menarche. So what was driving earlier age at menarche, and importantly, what could be contributing to an increased risk of breast cancer for populations? And so I had this question of, could it be that what's driving this are differences in what people were being exposed to within their environment? And could people just across the board be being exposed to this, but are there certain groups that are being more exposed in general? And we created this environmental discrimination and health model. This model really arises from the fact that if you look at this model, and I won't, I'll walk you through this as we go throughout the presentation, but I want to highlight the far right-hand side where you see individual level factors. So as an epidemiologist, we hyper-focus on the exposure, highlighted here in yellow, and a health outcome. So I was really interested in these environmental exposures, particularly these environmental chemicals and risk factors of breast cancer. And I would look at, assigned group membership. Again, I could be race, it could be socioeconomic status, it could be those ability differences. I was looking at race and ethnicity. But we typically kind of put that into our math and we kind of adjust it away. And I was interested in understanding why were we seeing the differences in the first place. And I didn't want to, in the context of it can't really be being driven by genetics, and race is a social construct, it's not biological. What social factors could be driving this? So I asked the question, are there behavioral differences that are driven by social or even cultural factors that could be driving some of the differences that we see with respect to the types of breast cancers people are getting, when people are getting breast cancer, and whether or not they're able to kind of navigate that, diagnosis for longer survival. So that led me to launch something called the Greater New York Hair Products Study. So as a doctoral student at Columbia, I launched this study. And I wanted to specifically understand what was the role of hair products. And the reason why, you might say, okay, you just mentioned air pollution and metals and these chemicals, but I was really interested in this because I ran across a case series. This is when a doctor has one interesting case and writes this up. And in this particular case, Dr. Chandra Tiwari had written up a case about hair products. And he found, or rather, there were 4 families that had come to see him, and all of the children, ranging from 4 months old to 4 years old, had been diagnosed, or had been showing rather, breast and pubic hair. So I said 4 months old to 4 years old. So these are very young children. They should not have breast and pubic hair. This is a condition called precocious puberty. And so he asked these families all sorts of questions. What did they use on the children? And, soaps, lotions, all sorts of other things. But he had a hunch, because one of the things that he noticed was A, all of these children were Black children, and B, they were all using hair products on these young Black girls. And so he actually sent the hair products out for independent testing and found 3 different forms of estrogen not labeled on the products. These products were products that you could easily pick up from a local, drugstore. So the parents did not know that the products contained these forms of estrogen. And when he told the families to stop using these products, the breast regressed and pubic hair fell out. And I had this kind of aha moment. Is it possible that maybe it's not just estrogen, but there's also other chemicals that are being put into consumer products like hair products that are marketed to individuals for a variety of reasons, but mostly because for beauty standards, that could be driving differences in exposure levels and subsequently increasing the risk of breast cancer through increasing the risk of certain developmental risk factors. And so I asked this question, are there differences in racial and ethnic hair product use? And was hair product use at all associated with earlier age at menarche? And then I also wanted to know, did these products contain hormonally active ingredients? I asked what types of products people used, the brands, and frequency and duration of use. And this was really a mixed method study. So what does that mean? That means that we had focus groups. We got people together and we asked them questions about the products that they used. And then we also did a quantitative study. In those focus groups, we learned a lot. We learned about all the different ways in which people use products. We learned that sometimes people chopped up birth control pills, put them in leave-in conditioner, heated it up, and applied it directly to their scalp, a very porous tissue that is able to uptake chemicals. We also learned that people had their own kind of do-it-yourself, like use mayonnaise and egg and avocado and honey to make their own products. So once we then took the information from the focus groups, we developed questionnaires and asked individuals about all of these different types of hair products, and we had a label book that helped aid in people's memory of the products they were using. We recruited over 350 individuals from around the greater New York area, and we learned that indeed hair product use did vary by race and ethnicity, and Black individuals are much more likely to use all of the different types of hair products that were identified in those focus groups, and particularly hair oil use. You'll note, and we've noted that hair oil use seems to be the bad actor, and I'll highlight that in just a couple slides from now. But we are also curious, I mentioned to you that when Dr. Tawari sent out the products that the families were using on their young children, that they contained ingredients that were not on the label. And there are certain things that will typically be on a label, such as if you're using a personal care product like a lotion or so on, and you're at home, you can turn it over to the back. It might say something like fragrance, for example, or paraben. So there's certain things that you may more commonly see on a label, but this is like, the point is that this is really underreported, but just based on the label and the ingredients that we know can disrupt the body's normal hormonal processes, also known as the endocrine system. So these are endocrine disrupting chemicals that based on the label these products contained. We saw that almost 50% of African American individuals were using products that contained these endocrine disrupting chemicals or hormonal disruptors, compared to about 7% of non-Hispanic white individuals. So, again, that's worrisome because this is not all of the ingredients are included. Companies do not have to fully disclose all of the information. We don't require that here in the United States. But there are some law and policy changes that are happening to try to improve this. But there's also this issue of people just simply not knowing that some of these chemicals and chemical ingredients are hormonally active. Sorry, here we go. So what about that question about, is there a link with age at menarche, this breast cancer risk factor? And what we found were hair oils and hair relaxers were associated with about a 40% increased risk. So the individuals who used hair oils or relaxers were 40% more likely to reach menarche or start their periods at less than age 12 compared to people who did not use these hair products. What was interesting was that we looked at duration of use and frequency of use. And what we found was that hair perm and relaxer finding might actually be attributed more to once a girl starts her period, they then started hair relaxer use. But hair oil use, the longer you use the hair oils, the more likely it was that you started your period earlier. And we followed this up with another study actually to see whether or not another population saw these same associations, and to also look at not just less than age 12, but what happens if you get earlier and earlier. And here, what I'm showing you here is if you cut off, instead of age 12, you cut off early periods starting at age less than 11, we saw that hair product use overall, but specifically hair oil use, was associated with over a twofold increased risk of starting your period at less than 11 years of age. So I bring this up for two reasons, because if you just focus in on the problem, okay, it looks like there's higher concentrations of these chemicals in, certain groups, in this case, Black individuals. It looks like they have a higher risk of mortality, perhaps due to earlier onset of breast cancer. It's diagnosed at earlier ages, but also these harder to treat breast cancers. And I just stopped there. I've not done anything about it, but now I'm looking at something that I can modify, that I can change. And that's really, at the end of the day, people want to be able to do something to improve their health. And we want to be able to empower everyone to be able to do that. So when we're thinking about this, we want to think about, well, what was in the products in the first place? Because it's, if I'm thinking about this at the individual level, as an individual, I may want to avoid certain things. So there's a variety of chemicals that we shared our most commonly used list with investigators, and independent testing was done. And every single one of the commonly used hair products contained, multiple forms of these hormone altering or endocrine disrupting chemicals, ranging from the parabens and phthalates that I mentioned earlier, but to other things that are hard to pronounce, like cyclosiloxanes, for example. And what's also important to note is, if you go into a store, the assumption might be that the product that I am purchasing, whether it's my, body lotion, soap, toothpaste, in this case, hair products, that those products, when I apply them to my body, do not have the ability to change my body's hormone receptors, or how the body's hormone receptors are acting. And yet, what we found with these commonly used hair products, for example, here I'm showing you, we tested a handful of different hair products. And if you look at the row across, so for this first one, hair lotion, it was able to upregulate, increase the activity of the estrogen receptor, what the estrogen receptor was doing. It lowered or decreased the activity of the progesterone receptor. 0 means it didn't really do anything either way. But if you look across at each of these products, every single one of these products was able to alter the body's hormone receptors. And so I don't know about you, but I don't want a product that I am purchasing at like my local drugstore that's not a medication to alter my body's hormone receptors. And importantly, many of these receptors are involved in breast cancer. And so, thinking about, well, how would this even connect the dots? And what can we do about it? Being able to say to someone, let's find a safer hair product for you, might be helpful in reducing their disease risk. Moving to a different time period, different time window, I will just note that we're now moving to pregnancy, and I just want to highlight preterm birth as a pregnancy complication. It's one of the most common pregnancy complications, and it confers roughly, there's studies that suggest anywhere from as low as 3% to up to 25% increased risk for breast cancer. But importantly here, the association, or rather looking at these differences, I just will highlight again that Black individuals are more likely to experience a preterm birth, and it's about 50% higher among Black individuals. I want to highlight these chemicals and pregnancy itself as a sensitive window of exposure to these chemicals that I mentioned before are kind of connected to, they're plasticizer chemicals, and they're connected to these personal care products. So in the first panel on the left-hand side, monobutyl phthalate is a metabolite of dibutyl phthalate, which is used in things historically like nail polish and so on. And monoethyl phthalate is a metabolite of diethyl phthalate, which is used as a plasticizer to hold fragrance in products. And we're looking across pregnancy within a cohort that's based here in the Boston area, the Life Codes Pregnancy Cohort at Brigham and Women's Hospital. And we tested urine samples for these chemicals across 4 time points in pregnancy. And what I'm showing you here is for the left hand panel, Hispanic individuals maintained higher concentrations, significantly higher concentrations of this butyl phthalate chemical across all time points in pregnancy. And then on the right-hand side, both Hispanic and Black individuals maintained higher concentrations compared to non-Hispanic white individuals across pregnancy. But you see this dip, and this really gets into the, the why, because I don't think the why just stops at, identifying the environmental exposure, but it's the why so that we can do something about it, so that we can achieve better health for all. So just to make note, and why does this even matter? But as it relates to breast cancer risk factors, I said preterm birth is a breast cancer risk factor based on several studies. And here, what I'm showing you is some of these phthalates are associated with an increased risk of preterm birth. And so if we're going to look at not just the environmental exposure, like those phthalates, and the health outcome preterm birth, but we're going to look at the behavioral factors that may be driving the exposure and the health outcome specifically, then we might want to ask, are there differences in what types of products, particularly personal care products, that different groups of people are using? And so we published this work looking at this question and seeing, for example, that for hair gel use, perfume use, nail polish use, I hope that that's kind of jogging your memory now, maybe getting more familiar with these plasticizers. So I mentioned that the the nail polish, those butyl phthalates, the perfume use, that ethyl phthalate, diethyl phthalate, that's more common in the Black and Hispanic populations, which are represented by the red and the purple bars here. So more of those individuals reported use within the kind of 2 days leading up to providing a urine sample during pregnancy. So we, on the flip side of that coin, see more cosmetic use among non-Hispanic white individuals. These are, again, those pregnant, this is a pregnant population, but these are some of the products that they're using during pregnancy. But does product use, does it actually look like people who use those products have higher concentrations of the chemicals? And this is something that's called a heat map. We use this a lot in public health research. And where you see red, it highlights higher concentrations. Where you see purple, it highlights lower concentrations. Across the bottom, I list out all the different types of products people are using. Across the, looking vertically, it's all the different, those different phthalate metabolites, so the different chemicals. Again, the top chemical is that kind of fragrance associated chemical. And I highlight here in the blue box hair oils. I mentioned that those seem to be a bad actor, and that MEP, which is a metabolite, again, of diethyl phthalate, it's that fragrance associated phthalate. For people who used hair oils, they had levels of this chemical that were 125% higher than people who did not use this. So again, this is getting into people's bodies, whether it's through, lotions that are fragrance, hair products that are fragrance, it's getting into people's bodies, and it's leading to higher exposure. So we asked the question, is there an association between hair product use and preterm birth? And we asked that multiple times across pregnancy, from early to mid to late pregnancy. That ranges visit 1 through visit 4. And we asked about the frequency. Did you use it daily? Did you use it less than daily? And what we found was late pregnancy daily use of hair oils, which are highly fragranced. It was associated with an 8-day earlier delivery. And there's if for those who are not obstetricians, and there are very few things that are associated as far as risk factors go with that clinically relevant more than a week earlier delivery. So again, is this an opportunity where we can say to folks, I'll note less than daily didn't have that same significant association. So is this an opportunity to be able to do something about it, for example? I'll just also bring to your attention, we also saw differences in birth weight for gestational age, and this is looking at people who use the products daily in the green dashed line, people who used it less than daily for hair oils, and people who didn't use this at all in the blue line. And you'll note this is going, if you look at the x-axis from left to right, the further to the left you go, the lower the birth weight. In this case, it's accounting for the gestational age in which the baby was born and kind of standardizing it. And what this really speaks to is people who used hair oils daily had significantly, have babies that were born at significantly lower birth weight in the order of about 300 grams, which again is non-trivial. And I just want to draw your attention to the green distribution line, where you can see more babies were born much lower birth weight. That's why you see this kind of additional spacing here. Okay. The challenge, though, that we have often in public health research is that we really focus in on the individual. And while we want to empower individuals to really think about what they can do themselves, it's worth noting that we, often can't do things for ourselves by ourselves. We're not expecting people to be chemists and go and find products and, decipher all of these kind of components. It's really important to think about what we might find within our neighborhoods, how we might even go on to impact policy. And had an amazing student work with me who recently graduated, Dr. Marissa Chan, who really was interested in, it's not just in what people are using, but asking why again. Why are you using what you're using? I don't know about you, but if I need toothpaste, I don't order it online. I go to the closest store I can get to in my neighborhood and pick it up from the neighborhood store, the neighborhood local drugstore. And so Marissa really asked this question, like, how does availability and access to safer products, how does does that differ by communities? Sadly, it does. So what Marissa did, and along with our research team, is we went all over the city of Boston. Boston has 24 neighborhoods. And we looked at, we went in and we collected an inventory of hair products. And we came back, plugged that into Environmental Working Group's risk score, because it's one of few risk scores that actually have a quantitative number for the risk score based on the ingredients list. And we were curious, again, is there an association based on the percentage of people of color within a particular neighborhood, as well as the percentage of people living below the poverty line within a neighborhood. And what we found, and this is just an example from a story map that we developed that is an award-winning story map, we won a prize for this, that communities like Mission Hill, which is a community predominantly people of color, lower income community, it's also the community that the School of Public Health here at Herbert Chan happens to sit in, but it has more than twofold increased odds of having more harmful chemicals or harmful hair products in the local kind of drugstores in this neighborhood compared to, say, Beacon Hill in downtown Boston. And that's worrisome. That means people don't have access to safer products. They also, these same stores also had more leave on products. So these are products that had more harmful ingredients. You leave them on compared to products that you would rinse off. And so that was also worrisome. And so this leads me finally in this last kind of portion of this talk to, really getting to what happens when we can ask why. So in our world, we observe these differences, like the differences in breast cancer risk, more challenging disease to treat, more mortality. And we observe that in public health research and epidemiology, in particular, we ask, what might be driving that? And I mentioned some of those kind of traditional risk factors. I also mentioned some of the environmental risk factors. We've done a lot about who's at most risk. where might that be happening, like some of the work Marissa's doing, when we focused on 2 time periods here. How I haven't spoken a whole lot about, but I did talk a little bit about the fact that these chemicals were able to change the way the body's hormone receptors were operating. But it's in asking why that we can start getting to solutions to these disparities so that we can develop interventions so that we can indeed achieve the goal of improving health for all, not decreasing any one group's health, but rather raising everyone's health. And so some of the work that we've done with respect to this is really through academic and community partnerships and co-researching. This was also a part of the work Dr. Marissa Chan, here she is on the left-hand side, did, where really she was not just curious about place, but what did community members say the solutions are? We're often very much positioned to think we as scientists know the best, and we really don't. We're often not a part of the communities in which we serve, and it's in serving others that we can better listen. And so we designed what's called a photo voice research project, where the community members served as co-researchers with us, in partnership with us, and we asked them about their experiences, facilitators, and barriers to finding safer hair products. And then we did 2 art shows. This is one of the community members speaking. They had a lovely turnout, and they provided some solutions. I'm just showing you here this concept that was highlighted and written about by one of the community participants, as far as a barrier that you can walk into a store and it may feel overwhelming and very time consuming to find safer products within a particular store. I'll also note that there are differences with who community members believe should be involved in the solutions. And while as scientists, we often think that our job is to connect solely with policymakers, the community members felt very strongly that community and community organizations, in this case, hair professionals, researchers, and clinicians needed to work together, and that they really didn't trust small or large businesses to be a part of this process. To harness the power of working with a clinician, we designed 2 studies. One was a study called iHelp, focusing in on improving environmental health literacy among clinicians. And at the beginning of this talk, I mentioned many of us might go into a doctor's office and the doctor never asks us about the environment that we live in. In part, that's because at medical school and nursing school, environmental health is not a core competency area and is rarely, if ever, covered. And so we really saw this as an opportunity to improve and increase the learning around environmental factors as it related to these health outcomes. And then we started the DEEP study, which was working with doulas to do something very similar. And these were narrative-based initiatives that also integrated and worked in partnership with the Pediatric Environmental Health Specialties Unit, as well as Beth Israel Deaconess Medical Center. And what we found was we were successful. We were able to increase the environmental health literacy of clinicians, showing you we gave a pre-test of what knowledge, what information the clinicians knew about these plasticizer chemicals and other personal care product chemicals, and then we did a post-test. They all improved their score. The higher the score, the better the score was for these. And most importantly, we followed up with them 2 months later to see had they integrated conversations about environmental health and environmental risk factors, particularly as it related to reproductive health, into their practice. And it went from 2% of clinicians to over 90% of clinicians talking about environmental factors with their patients. Importantly, if you improve someone's environmental health literacy, you decrease their exposure to these harmful chemicals. And that's what I'm showing you here, particularly as it relates to protective behavior factors and regulatory interest. There are a variety of other things that we've done, ranging from, I mentioned the story map that we won awards with, but also working with middle schoolers and elementary school students, as well as high school students, around environmental health and health disparities. We partner with an organization, Bethel Institute for Community Development, to do this work. We also have a variety of community events ranging from events on water concerns, food security, and personal care products. Even one of these pictures is focusing in on people making personal care products. And then also we have a Beauty Plus Justice podcast. And to just end and wrap up, we really want to even move further out to the structural factors and thinking about how might we change both big policy with the capital P that people often think about around laws and kind of at the state or federal level, but also thinking about policy with a lowercase p. How can we change these things? So in thinking about this, I've served on the National Academies Committee that was focusing in on those forever chemicals, those PFAS chemicals, and the testing and health outcomes, and providing reports that could really help, engage clinician and clinician groups around how do you address this, contamination issue that it really is a national issue and challenge. Policies such as the Crown Act, the FDA reviewing the banning of formaldehyde, and just added attention even at the international level. The hidden cost of Black hair was actually a feature that was done by The Economist in the UK. So this really taking off of these discussions that are happening that are really centering the environment and women's health. And I'll just end with, the Massachusetts Breast Cancer Coalition is also leading the charge in so many ways around policies with a capital P. These are 3 different bills that they are working on. And I'll just say to you all, you can do something. You can ask why, you can show your leadership, and most importantly, you can make the world a better place for all of us, like Margo did. So thank you for your time. I'd like to acknowledge my research group and team, our funding organizations, and I'll transition to questions. Thank you.
Tamara, could I ask you the favor to just back up your slides to the legislative slide that you just shared, just so that our members can and participants in today's webinar can take a look at that. And really, this is a call to action. We are looking for advocacy around these bills that will impact the environmental factors for all communities, all women experiencing the challenges of health issues that are associated specifically with being women. Thank you so much, Dr. James-Todd. A very informative presentation. We are going to begin the Q&A section just for a few minutes. If you are interested in submitting a question for Dr. James-Todd, go to the questions tab on the GoToWebinar control panel. And in the meantime, I'm going to ask you one question that was early on in your presentation around, when you go to the doctor, you fill out pages of information on family history, on lifestyle factors. And some of those questions, have become now required questions for your care provider to ask, which is great. But I don't think in all my years I've ever been asked about the potential of environmental factors. And I wanted to ask you why. Why do you think that is still not considered a part of mainstream clinical care to include in our discussions around our own personal health and breast cancer risk?
Yeah, I think there's multiple layers of reasons why that might be the case. And I'll just highlight 2. Dr. Calvin Elliott, who is an environmental philosopher, spends a lot of time thinking about the values that our society has in saying what is of importance and what isn't of importance. And so I think it's really interesting, and perhaps we make it very clear that despite the fact that we know about 10%, like overall, and then we're not just talking about breast cancer, but like our overall health, roughly about 10% is driven by our genetics. The other 90% is driven by the environment. But it's fascinating that in medical education, whether you're talking about medical schools or nursing schools, the two environmental factors that are covered as a part of, in other words, what the value is of this information is, it's covered in two parts. One is lead for pediatric patients, the other is mercury for pregnant patients. So the fact that we don't value, we as a society, or in this particular case, in kind of medical education and training, the importance of the environment. And so it's not that clinicians don't care, they don't know how to ask those questions. There are resources like these, electronic medical records that are intaking this information. They don't know how to query about it because it's not something they've been trained in. And so that was really the impetus for our launch of the iHelp and Deep Studies. And what was also fascinating about that was that there was a real thirst for that information. In that we initially had only planned to recruit about 100 people into that study, like no more than 100, and it actually snowballed. We ended up with 200 participants. We had to cut it off and make it really clear. People kept coming to us. And so there's a thirst for that knowledge and information, and I think we should leverage that with respect to the integration of some medical schools are integrating climate into their curriculum. That's not across the board, but some are integrating that. Others are integrating and in need of thinking about these PFAS or forever chemicals because many communities are impacted by
it. Before I get to the last question that we'll take, Dr. James-Todd, there have been some questions about where could people find information? Where is there a list regarding these chemicals? And what I will tell folks is that if the mbcc.org website, if you go to the resources section, it is rich with resources for you. In addition, you will see that there's information for an app that you can have on your phone called Detox Me, which will allow you to be a better consumer and to advocate for yourself. And allow you to use that app on various products to identify what environmental factors might be at play with that particular product. I use my Detox Me app every time I go to the store. So this great question here, do you know if there are any community interventions that have happened since your research regarding hair product use?
So I do. What's been really, when I first started this work, there was really a limited understanding of the importance of, particularly in the beauty space. I mentioned beauty justice, but these consumer products that are kind of in the beauty space being important sources of exposure to harmful ingredients. And what's really been beautiful to watch is an increased awareness of these conversations, both among community members and whole community groups kind of coming together and working together with these kind of community academic partnerships. So beyond us thinking about We Act and its collaboration with Columbia University and the work that folks are doing out in California, there's a lot of ongoing work, but again, with organizations like breast cancer prevention partners and academics, Black Women for Wellness LA, that's doing a lot of work in this space as well. So there's a lot happening beyond just our lab here. And not to say, I think a lot of this is organically happening independent of the work that I did, but certainly I think it synergistically has the power to make things healthier for all of us.
Again, thank you so much for this very informative presentation. That's all the time we have for questions today. Thank you again. We appreciate you taking the time to share with us today and to continue the good work that you're doing.
Thank you so very much.
Oh, you're very welcome. This is the 5th annual Margo Simon Golden Memorial Webinar. Margo had a vision for the role that Massachusetts Breast Cancer Coalition could play, not only for the citizens of Massachusetts, but for the greater good. Through her actions and advocacy, she paved the way to change the world for future generations. Margo's husband, Neil, along with her stepsons, Andrew and Craig, and other members of the family, have been instrumental in supporting Massachusetts Breast Cancer Coalition and our mission over the years. It is my honor to introduce Andrew Golden.
Thank you, Dr. Malkus, and thank you, Dr. James-Todd, for that wonderful presentation. It is difficult to believe that it has been nearly 5 years since Margo died of metastatic breast cancer after having lived with it for more than 2 decades. While there's nothing magical about round numbers, they do carry a certain weight. The first anniversary, 5 years, or 10 years. When you love someone, it can be overwhelming to comprehend the growing distance of time since they were here physically. But as we each know or come to learn, the people we love are never distant in spirit. Margo was a true champion of the cause of the Massachusetts Breast Cancer Coalition. She was tireless as the organization's president for many years. She never missed an opportunity to engage in her own soft-spoken but firm approach to advocacy. Whether it was testimony at the State House, raising funds, investing countless hours in the MBCC's education and outreach initiatives, or as my father very recently reminded me, leaving Massachusetts Breast Cancer Coalition pamphlets in the gift shop of the Beth Israel oncology floor during her own treatments. She never stopped pushing for a better future. However, as I can never let go unmentioned in these circumstances, it is not quite right to define or even to describe Margo as a, quote, fighter for a cause. While that was true, we miss her so terribly for all the things that don't seem to always make it into a person's posthumous CV. She was an exceptionally warm and caring person, a calm and supportive presence in any storm while going through her own, a cherished spouse to my dad, parent to my brother and me, and nanny. She was a beloved daughter, sister, cousin, and aunt. She was an unwavering friend to those she held dear, including our organization's executive director, Cheryl Osimo, and other board members and volunteers with the organization throughout the years. In determining whom to give this award to each year, we of course focus on a commitment to the same issues that the Massachusetts Breast Cancer Coalition exerts all of its energies to advancing. But that part's a given. We also try to think, just as we do in our personal lives, what would Margo do in this situation? Whose work would she value? Who would she want to present to the public as an example of the good one can do in the world? Even these 5 years after losing her, Margo's voice still sounds clear. And that is why the Golden and Simon families are honored to bestow this year's Margo Simon Golden Distinguished Service Award on Dr. Tamara James-Todd. As someone who gets tongue-tied talking about science, I am deeply gratified that for the first time in the growing history of this award, it is being bestowed on the same individual who served as the speaker. Because of that, I don't have to use my liberal arts degree to try to summarize Dr. James-Todd's work, because you just heard it. As you saw from her excellent and informative presentation, Dr. James-Todd is a powerful and passionate advocate for the same issues that were so important to Margo. Dr. James-Todd marshals her strong technical expertise to address breast cancer not merely as a disease, but as a matter of justice, environmental, racial, socioeconomic, and otherwise. As Dr. James-Todd observed throughout her presentation, it's the question of why, not hopelessly, but as a motivation to make a difference. And for those who are attending today, if that is also important to you, I invite you to visit the MBCC's website, mbcc.org, to get involved, to have access to learning materials, or to donate. Dr. James-Todd, on behalf of Margo's family, and by extension, the MBCC organization that supports this award, it is my privilege to give you this year's Margo Simon Golden Distinguished Service Award. Congratulations and thank you.
I just want to thank you all. I'm trying not to get teary here. this was the beautiful award. I don't know if folks can see this. This is the beautiful award that was sent to me. And I wish that I had had the opportunity to have met her, but I feel like I am getting that opportunity today and throughout the process of learning about her. I feel this kindred connection in being able to continue her legacy and to also pass that to my students and to remind them to remember their why. I've commissioned an art piece for our lab that says that, remember your why. And I hope that the family and the MBCC colleagues and that any of the listeners always remember your why and why you are here, your purpose. It matters. And I hope that Margo continues to inspire the lives of everyone attending this webinar to go out and to make the world a better place for all. So thank you so much for this honor, and I'm deeply grateful.
On behalf of the entire Golden and Simon families, Massachusetts Breast Cancer Coalition's Executive Director, Cheryl Osimo, and the MBCC Board of Directors and MBCC staff, we would like to again thank Dr. James-Todd and all attendees for participating in the 5th annual Margo Simon Golden Memorial webinar. For those interested, the recording of this webinar will be made available later today on the MBCC website at mbcc.org. If you'd like to make donations to the Margo Simon Golden Fund to help continue the mission that she fought so valiantly for, please visit mbcc.org/tribute. Thank you for joining us. Have a good afternoon.